food intolerance is different than a food allergy, as in this can be physically uncomfortable, but it doesn't involve the immune system response. Common foods that can cause would be like lactose. So we've talked about lactose intolerance before. We all know what that looks like. And the treatment is going to be different to food allergies. So we can use products that contain less lactose. We can use medications to help break down the lactose. Um, Whereas I cannot do that if my child has a food allergy. A frequent cause of food intolerance is going to be sulfites, which is a food preservative found in shrimp. MSG, monosodium glutamate, is also another common food intolerance. It can trigger migraines. All right, let's talk about eating disorders for a little bit now. Oh. And so eating disorders are going to be a psychological issue. It is not just, oh, we just need them to eat a little bit more and they'll be fine. It is actually it's in the DSM-4. And so we have three ones that we're going to talk about: anorexia nervosa, bulimia nervosa, and binge eating. We see this more in women than in men, but men are still susceptible. And we see some sort of disordered food consumption or impaired perceived image. So up here, for example, this is what an anorexic nervosa would normally look like, and they might look in the mirror and still see, might see this body image, for example. They usually tend to have a lack of coping skills, and they may try to keep this secret. So here is just a list of some common nursing diagnoses that we would use with somebody who has eating disorder. And then you can see here is also then the etiology and risk factors a lot of times, especially in the United States. Our culture is obsessed with thinness, and so that can really do a number on, especially in adolescents. All right, let's talk about specifically now anorexia nervosa. And so we can see that this is life-threatening. They're starving themselves. They're going to have putting themselves at fluid and electrolyte imbalances. So what are we going to need to assess? We're going to assess for any weight loss. We're going to need to look and see for any electrolyte imbalances. So actually grab us lab values, look at those potassium, sodium, chloride. We're going to typically see dry, scaly skin, amenorrhea or loss of menses, because the body is trying to conserve. It cannot let iron go out through a monthly menses. We're typically going to see constipation in the GI tract as well as tooth and gum breakdown. The treatment here is going to need to be an eating disorder unit and behavioral modification. We're going to continue to assess their nutritional status. And in severe malnutrition, we can use medications or tube feeding and the refeeding protocols, but we really do want to avoid that whenever possible, because when you use like tube feeding, the patient no longer has to physically put the food in their mouth, and so that, again, this is a psychological disorder. That is where a lot of the issue comes in. Our goal is going to be for normal or near normal nutritional status and them gaining about 1 to 2 pounds a week. We want to do things like set a time limit for meals, do contracting, have a pleasant environment, do positive reinforcement and feedback for appropriate eating behaviors. We want to be doing daily weights and monitoring intake and output. We also want to assess for suicide risk and implement precautions as needed. All right, bulimia nervosa. So this is going to be the cycling. An average of 2 binges per week for 3 months leads to the diagnosis. This may occur in secret or as a group activity. And so what we're going to see is we're going to find normally their weight is going to be normal or near normal. But again, there's going to be those electrolyte imbalances, especially low levels of chloride, sodium, and calcium in the blood, because again, they're throwing this up. Low calcium is going to lead to cardiac issues. So that we need to do an in-depth cardiac assessment. We're going to typically see things like high blood pressure. In the GI tract and the teeth, we're going to see loss of enamel, stomach ulcers, and can be rectal bleeding and esophageal varices, because the binging and purging the purging does not have to be all oral. They can also purge through using laxative and enemas and diuretics, and even going to amphetamines. And then BED, or binge eating disorder. This is at least once a week for 3 months. We see larger amount of food than normal in less than 2 hours with a lack of control, so a compulsive overeating. There are many reasons for people to binge. Everyone uses food to meet their needs other than hunger sometimes. So just because one time you know, you did bad on an exam and you go out for ice cream does not mean that you are now a binge eater. Um, but if it becomes a pattern and the person's peace of mind is compromised, there may be an underlying eating disorder. 40% of the cases here are male. This was just in 2013 added to the DSM-5, the newest manual. Complications. People who are obese and also have binge eating disorder may be at greater risk for several potentially life-threatening complications, including type 2 diabetes, high blood pressure, high cholesterol, gallbladder disease, heart disease, cancer, osteoarthritis, joint and muscle pain, GI problems, depression, anxiety, sleep apnea. And so we're really going to need to assess for all of those. And we want to, definitely be doing daily weights. We could be doing food. We could do food journaling as another intervention here. So here is just a beginning of what are some of the psychological food eating disorders.